welcome to another video of TheSynapse. With us today we have Dr. Myra Tilney, a consultant in primary healthcare and also a senior lecturer in the Department of Medicine with a focus on cardiovascular disease amongst others. She will be speaking to us today about aspirin and its use in current contemporary medicine. Welcome, Dr. Tilney. What can you tell us about aspirin, its mechanisms of action and risks associated with it?
Well, aspirin has a dual effect. Its primary event for which we like to use it is that it's antithrombotic. It interferes irreversibly with the COX-1 system, which is responsible for promoting clotting by promoting platelet adhesion. It then has another action by interfering with the COX-2 system, and this is very important for vessel relaxation, for renal perfusion, and for reducing platelet adhesion. So it can both reduce thrombosis and promote hemorrhage and bleeding. And in fact, this brings me to the harmful effects of aspirin. It does promote an increased risk of bleeding, more or less doubling it on average. It's associated with bleeding into the gut and brain in particular. It causes chronic kidney disease and is associated with renal dialysis, and it may also be associated with hearing impairment and age-related macular degeneration. So the harms are not insignificant. But this leads us to this dichotomy as to when to use it.
Exactly.
And
taking into account the pros and cons, then what are the current guidelines in this regard?
Okay, well, let's talk about which patients we're discussing, first of all. If we're talking about patients who have established cardiovascular disease, somebody who's had a thrombotic stroke, somebody who's had an infarct, in that case, there is clear evidence, going right back to the 80s, that it is preventive. Okay, there is a net benefit when we look at the risk-benefit ratio. There is a net benefit to using aspirin, certainly in the short term. There's actually a paucity of information with regards to the long term, but it is established practice to continue it today, although there are questions still being asked about that situation. But that's current practice. Now, when we talk about low-risk individuals, it is being used quite widely, and there are one would think, why? Well, there are different reasons why it may be used as primary prevention. For a start, people extrapolate from the tertiary situation. We know it's effective in stroke and infarct, so we think it could be useful in preventing such disease. And this is not a small matter, for the simple reason that cardiovascular disease on a worldwide basis is the major cause of death. And in our country, it's responsible, at the last demographic data, it accounted for just under 47% of deaths.
Quite high.
That is high, obviously.
Very, very high.
On a worldwide average, the death rate for cardiovascular disease varies, but in general, up to around 24%. So we are, in general, still a high-risk country for cardiovascular disease. Although in terms of the WHO criteria, we actually classify as low risk, interestingly enough. But when you look at the actual statistics, we have a heavy burden, and that's something that has to be kept in mind. So why is aspirin used in primary prevention? There are various reasons. One could be extrapolation, and I'll go into different reasons as to why it may be used. But before I get into that, I'll just give you the answer quite simply. The European Society of Cardiology in 2012 came out with a very clear statement saying aspirin cannot be recommended in primary prevention due to its increased risk of major bleeding. It's clear-cut. Okay, that is a statement by the European Society of Cardiology Guidelines, which can be seen on their website. Okay. Interestingly enough, the Food and Drug Administration of the US earlier on this year, in February to be exact, put out a statement on its website. It had been asked to include a statement that aspirin could be used as prevention by pharmaceutical companies, but in fact, when they reviewed the literature, they again also came out with a statement saying they reviewed the available data and they do not believe the evidence supports the general use of aspirin for primary prevention of a heart attack or stroke. Again, quite unequivocal and clear. Now, but here we're talking about patients who do not have
healthy individuals.
They are healthy individuals. So causes me to ask questions, because even in this clinic today, I still had a couple of patients coming in on aspirin as primary prevention. It is widely used. It's not only in this country, it's
so although
worldwide.
there's this guideline, there's this gap between...
Well, we always know that in medicine we have what we call a knowledge translation gap. We know something does work or doesn't work. Until it becomes translated into regular clinical usage, it takes time, which is why such videos are actually really interesting in promoting what we call e-learning, in encouraging better translation of evidence into practice. So I think this is a really good initiative to promote.
Dr. Tilling, we've spoken about a healthy population and the role of primary prevention in aspirin. What about high-risk populations?
Okay, at this point I'll refer you to the pooled meta-analysis that Seshasai published in 2012, and he included 9 randomized control trials which pooled together came to 100,000 individuals, and the evidence was graded as moderate. Okay, and he found, and I'm going to talk about absolute risk reduction, okay, he found that if you take 1,000 individuals, treat them for 10 years, you would expect about 100 deaths in low-risk individuals. Okay. Now, with aspirin, you could reduce this by 6 deaths, it's thought, but the confidence interval varies from 0 to 12. Okay, and no significant difference. With high risk, the absolute death rate would be 136 individuals due to myocardial infarction, and you might expect between 5 and 4 perhaps reduced incidents. However, the death rate, the bleeding rate is more or less doubled. Okay, and the absolute bleeding rate would be in a high-risk group 40, and you would more or less double that to 80 practically. It's actually to around 70. Okay, so on balance, you reduce the risk of thrombosis, but you increase the risk of hemorrhage. And looking at the data, there was no clear way to identify who would be at increased risk of bleeding and who would be at increased risk of prevention. Okay, so this is where it gets a little bit murky. Some individuals, notably, for instance, Cleland in the literature comes out very strongly saying that you just cannot use it in this way. But others, for instance, there is an analysis where they actually suggest you should try to discuss it with the patient, show them the absolute figures, and go in for a shared decision-making type of discussion, mentioning the absolute figures. Okay, so here it gets a little bit difficult. But on balance, so far, the absolute balance is there is a very fine overall balance in terms of reducing strokes, but at the same time you increase the risk of bleeding. So it has to be personalized.
Aspirin is a well-researched topic. What are the current developments in this regard?
Okay, well, just as the cardiovascular story is becoming clearer, a new indication for aspirin comes on, which is that it may reduce cancer incidence. Now, there is a biological plausibility to this, because by interfering with the COX-2 system, it may actually help to reduce blood flow to tumours. So that's the biological basis. It's important to state that all the analyses for cancer are post hoc analysis. That is, there's been no prospective studies to date. Okay? Looking forwards, there are at least 4 studies ongoing that will be including this and clarifying it further. And those will bring in an increased pool of around over 20,000 individuals. So that should strengthen the evidence base further for us. But so far, the evidence with respect to cancer is post hoc, weak, and in general, they tended to exclude patients at risk for bleeding. Okay? But there were, having taken all that, it seems that there was an indication there may be some reduction. And if I'm talking about absolute figures, for instance, in low-risk individuals, you could expect 8 tumours over a 10-year period, okay, for every 1,000 individuals treated. And, I'll just rephrase that. You could expect 10 tumours, and with aspirin, you may reduce between 0 to 2 tumours. Okay. So we're talking about really small numbers, treating 1,000 people for 10 years in low risk. If we're talking about high-risk individuals, you could expect perhaps 100 tumours at those at high risk for cancers, and you may affect that by the reduction may be from 2 to 10. Okay, so we're talking about really small numbers. So this is, I think, a space to watch rather than to base evidence. There's no really hard evidence. It's
Until
intriguing. It's something to look at for the moment, but it's not something that you can comfortably have an evidence base.
We'll await the prospective studies then in this regard.
That's it, exactly.
In conclusion, what is your final message which you want to give to the viewers who are watching us today with regards to aspirin use?
I think I'd refer them to the European Society of Cardiology guidelines, which are clear and unequivocal in primary prevention, that it has no place, and that's also supported on the other side of the pond by the FDA. With respect to what we call secondary prevention in those individuals who are at high risk, you need to bear in mind that as aspirin reduces thrombotic risk, it promotes bleeding risk, so this is really a fine balance. And in reality, it's very, very difficult to identify who would benefit and who would have a net harm. The risk-benefit ratio is very close to call.
Thank you, Dr. Tilney. Thank you, the viewer, for supporting us and for watching this video. We hope it helps you understand aspirin and its use in current practice. Keep on watching TheSynapse, bringing content that matters to the busy medical profession.